so much. I am going to share my screen, and if I could request that I'm given a reminder or given just a signal when you have about 20 minutes in, just so that I know I can pace myself. So the first thing to say is that what I'm attempting to cover today, now I don't know if anyone has, how many of you have any prior knowledge of this subject. So I'm going to try and keep it really accessible. So even if you've not heard of this before, for those of you who are familiar with epidemiological study designs, what this should do is it should be a good refresher. I hope that we can finish in time with some time left for questions. The other thing to say is that if you only get 50% of what I say today, that's perfectly okay, because this is usually the first lecture in a 2-month module where we go deep dive into each of the study designs. But hopefully it's enough to get you started, and you'll have my slides, you'll have this recording so you can go over it again and just become clearer about it. So let me start sharing my screen. And when you can see my slides, please do let me know. So someone can just speak up and say if you can see the slides. Can't hear anyone?
Yes, we can see.
Okay, great. Now, just be aware that I can't see anyone at the moment. You're free to ask me questions as I go along, or free to interrupt me as I go along, but you will have to call out because I won't be able to see you. So let's go straight in, study designs for research. So what will I cover today? I'm going to provide you an overview of the 4 key epidemiological study designs, and these names will become more familiar to you as we go along this presentation. Ecological studies, cross-sectional studies, case control studies, and cohort studies. So these are known as epidemiological study designs. People often include randomized controlled trials, or RCTs. So just an interesting one. When I first went into public health, I was still thinking, RCTs, why are they talking about root canal treatments? But now I know that I'm properly embedded in public health, because the first thing I think when I see RCTs, it's randomized controlled trials. So randomized controlled trials are often taught as part of epidemiological courses, but they're not traditionally or technically an epidemiological study design, and I'll talk more about this later. Out of scope is some of the more complicated or unusual designs like time series designs, quasi-experimental designs. Quasi just means like, but not quite. So these are like experimental designs. Then I wouldn't be covering things like measures of effect. So how do you measure, or any statistical analysis, but we might make references to it today and tomorrow. So what you should be able to do after this, and not just after this presentation, but maybe after you've had a look at the slides and done some homework on your own, is you should be able to describe the key features of ecological studies, cross-sectional studies, case control studies, cohort studies, and randomized control studies. And my aim is that you should at least have a good understanding of the main strengths and weaknesses of each of these study designs, and be able to select an appropriate study design for a given research question. So going back to what is epidemiology? The epidemiology studies the distribution and determinants of health-related states. Yeah.
Hi, Puja. Ishpal here.
Oh, hi, Ishpal. Good to hear from you.
It's a very good lecture. Please continue.
Thank you. So epidemiology studies the distribution and determinants of health-related states or events. What do I mean by this? Yeah. Sorry. Is someone saying anything now? Can't quite hear. Right. Joe, unless you tell me otherwise, I will continue. Okay.
Yeah, ma'am, you can continue, please.
Okay, thank you. So epidemiology studies the distribution and determinants of health-related states and events. And by this time, because I've said it 3 times, it should be burnt in your minds. So what do I mean by distribution? It's things like some of the questions which I've given you there. So, which is like, what are the trends over time? So, for example, has pneumonia increased or decreased over time? Has polio increased or decreased over time? What are the places that are affected by a disease? Because you might have certain states or certain countries that are more affected by a particular disease than others. Which are the populations affected? So it might be that you have certain ethnic subgroups. You might have maybe the elderly or pregnant women who are more susceptible to certain diseases than the other. So that's what I mean by distribution. And determinants, you can think of determinants as risk factors. So these could be clinical characteristics. They could be physical factors. Physical factors could be as simple as gender. So, are men more susceptible than women? Are elderly more susceptible than the young people? Are there any other sort of biological mediators, or is it someone who has a high HbA1c level? Is that a risk factor for some things? Social and cultural, economic, behavioral are interesting factors, because poverty is an important risk factor as well. So, for example, we know that if you have poverty and you're living in crowded conditions, you have a poor diet. Sorry, was that again a question? Probably not, so I'll continue. So we know that economic, social, cultural factors can actually affect and modify health. And so are behavioral factors. We know that lifestyle factors play an important role, whether it's smoking or physical exercise and activity, whether it's the kind of diet you have. So this is what I mean by determinants. So I've given you examples of how you can frame an epidemiological study question in different ways. I'll let you read over some of these later because I've kind of covered them. But another important one is, what are the consequences of a particular disease? That is also an example of an epidemiological question. So you might want to study, say, people who have type 2 diabetes, or maybe someone with irritable bowel disease. Well, I know in dentistry you won't want to, but it's just an example. You can study the sequelae of that disease, and you can see what are the outcomes. Is it hospitalization, death, increased risk of cancer, etc.? All that is epidemiology. The other concept I want to cover up front is, what do I mean by observational versus interventional study designs? Now, epidemiological study designs are often referred to as observational studies. And what this means is you are just observing what is happening as nature takes its course. The researcher has no control over who is exposed to what, and you are not intervening at all. So you are purely observing. You are taking a passive role as a researcher. And so when I talk about ecological studies, cross-sectional studies, case-control studies, or cohort studies, they are all observational studies. In contrast, an interventional study is a study where it does what it says on the tin. You as a researcher are intervening. So you might recruit study participants, but then you randomly assign them to either receiving an intervention or not, or in other words, you're conducting an experiment. So they're also known as experimental studies. So the classical interventional or experimental study design is the randomized controlled trial, or RCT in my world, and they're used to study the effectiveness of an intervention. Quasi-experimental designs, which we're not covering today, attempt to also evaluate the effect of interventions, but they are done when you cannot do a classical randomized controlled trial because of either resources or ethical constraints or some other things. Types of interventions you can study. These could be medical treatments, it could be procedures, or a public health intervention. Believe it or not, there have been randomized controlled trials even of surgical procedures where people have gone so far to actually make an incision so that the patient thinks that they've received surgery, but not actually done the surgery. But the more typical one is with things like, we all know that medicines and pharmaceutical companies will use randomized controlled trials. That is seen as the gold standard. If you look at the hierarchy of evidence, you will see that not all studies are considered equal. And if you look at this slide, as you go upwards, it is considered that those studies designs are better. So right on the top of the hierarchy of evidence are systematic reviews and meta-analyses. We won't cover them today, but essentially these take a global view of all the studies which have been conducted to date, ideally randomized controlled trials, and then they pool that evidence to come up with a single best estimate of effectiveness or safety or anything. So they're considered to be at the top of the pyramid. Right at the bottom are the ecological studies. And in the middle, you have the observational studies, but generally speaking, randomized controlled trials have been considered the gold standard. Now, this is something we can have a philosophical debate at some other point, because it's not always necessarily the case. So it's important to have an open mind. So let's go into the first observational or epidemiological study, which is the ecological study. These are population level studies that compare groups rather than individuals. So an example of this would be, so let's say you're looking at all the different states in India, and for each state, you have some summary measure. So you might have, say, educational, some sort of like, maybe a percentage of educational achievement or attainment. And that is one measure you have for each of the states. And then you might have another measure in that state, which is for each state, you have some kind of way of encapsulating overall health status. And you just compare that and just plot them on a graph. And let's say you find that those states that have higher educational achievement have higher health status, you could then conclude that education is a positive contributor to health. So that is in principle what an ecological study is like. You don't have individual level data, you're just going and seeing what's there from survey data, from the literature, and you're looking at it ecologically. So ecological means like, you're looking at it, at an ecological level rather than an individual level. It's a good study design. You can do them really quickly. It's good for hypothesis generation. For those of you who are first year PG students, I would say that I wouldn't accept an ecological study for an MD thesis, but it could be part of your entire research portfolio in a PhD thesis. This would, because it's not sufficient in its breadth. Now, while this is lowest on the evidence hierarchy, in some situations, this might be the best study available to you. So for example, during the pandemic, and this was the 2009 pandemic, when I was involved in this, actually, it was a really good study because you had different countries had different approaches to dealing with the pandemic, and they gave oseltamivir, which is Tamiflu, for prevention of severe effects. And actually, Japan was a really interesting case because Japanese people are so compliant. Amongst pregnant women, there was almost 100% coverage. 100% of the women took Tamiflu. There were no deaths. Now, because everyone took that, you couldn't conduct those studies in Japan because there was no difference. However, by doing an ecological study comparing deaths in pregnant women from flu in Japan compared to other nations, you could then easily see that Tamiflu had an impact. So there are those kind of national level policies which can sometimes be best studied only using ecological studies. Now, there is a problem with ecological studies, which is the ecological fallacy, because you're using summary statistics at an aggregate level, and you're trying to then make inferences at an individual level. So let me give you an example. So let's say, again, I looked at all states in India, and I looked at fish consumption per state and risk of heart disease per state. And let's say I found that those states which had higher fish consumption had lower heart disease. I could conclude and say, well, fish consumption is really good if you want to reduce your risk of heart disease. And these were ecological studies that were done globally, but later studies did not seem to find that this held true. So they said, what was going on? Now, the problem is, you don't know in a given state that is the same people who are eating the fish who are affected by the lower heart disease. So this is where the ecological fallacy comes in, because you're just making assumptions it's the same people. So a study from dentistry of an ecological study, you could look at, does having a school-based fluoride mouth rinse program decrease dental caries in school children? And this was an ecological study done in Japan. They had 47 Japanese districts or prefectures. And for each of these districts, they had data on proportion of children receiving the SFMR in that district. And they also had the dental caries status, so the mean DMFD score for 12-year-olds for that district. So they were able to compare this. And what they were hoping to see was that those areas or those districts that had the school-based fluoride mouth rinse program would have a lower mean DMFD score. So that's a very simple ecological study. I've given the link to the paper. You may not understand all the complex stats and everything, but just read the study setup and discussion of the ecological fallacy, because depending on the context, the ecological fallacy may or may not be important. So again, don't dismiss this study as being completely pointless. It can be very, very useful. The next type of study is a cross-sectional study or survey. Now, this should be quite familiar to you, because this is the idea that you survey a slice of the population or a target population at a point in time. So you take a snapshot of what is happening with them. What this means is, so you know when you have the census surveys, you go door to door and everyone fills out a survey and returns it and you analyze it. That is a survey. You could invite people to attend a study, which is like a survey where you just do blood pressure measurements and you find out what the mean blood pressure measurements is. That's a survey. You could do HbA1c measurements, or you could look at type 2 diabetes. So you're just collecting data. Now, the important thing is, like, let's say if I wanted you to do a survey in Ludhiana, if I wanted you to include every single person in Ludhiana, that is a really expensive and resource-intensive affair. So for a survey, you would take a sample. What is more important is not how many people you have. To some degree it is, like we'll talk about that tomorrow, but that you have a random sample which is representative of the overall population of Ludhiana, so that, you know, any conclusions you draw from that sample are relevant and are generalizable. So this kind of study is really good to understand the frequency and characteristics of disease and risk factors in a population at a point in time. So what do I mean by this? So you can say, what proportion of people smoke? What proportion of people have an HbA1c level above this particular threshold? What proportion of people have type 2 diabetes? So it's this kind of stuff. And an example I've given there, which you can look up later, is a survey to measure the prevalence and severity of dental caries among adolescents in Tamil Nadu. So prevalence studies, if you want to estimate prevalence of anything, this is the study design you would use. The next study is a case control study. You start by identifying a group of people with the outcome of interest. These are known as cases. And another group of people without the outcomes, and these are known as controls. So for example, if I wanted to look at people with lung cancer, those would be the cases, and people without lung cancer would be the controls. And that lung cancer in this case would be called the outcome. Now, let's say I was interested in looking at the association between smoking and lung cancer. So smoking, the risk factor, is also known as exposure or the exposure of interest. So I would collect data on who smokes in both the groups, cases and controls, and then I would compare that. Another example is, let's say we want to compare people with asthma to people without asthma and study the relationship between cat ownership and asthma. So cat ownership, why? Because cat hair can be an allergen that can provoke asthma or, like, you know, lead to the development of asthma. So cat ownership here would be the exposure. Asthma would be the outcome. People with asthma would be the cases. People without asthma would be the controls. It's relatively inexpensive. It's faster to perform than some of the other studies we're going to discuss because it has no follow-up period. It's at one point in time. Let's say you've got the people and then you ask them about their history, and this will become clearer in my next slide. One of the things to remember, the golden rule, if you want to estimate the absolute risk or incidence of disease, this is not the study design to use. If we have time, you can ask me a question and I can explain this at the end. For now, just take it as fact. So case control studies illustrated. So let's say we want to look at people with cancer. So patients with the condition, that's the box with the people in green. So those are your cases. You have a comparison group or your controls, which are the non-patients. Once you have both these patients, you take a history and you're asking them many different risk factors, because that's the beauty of the study. You can study more than one risk factor at a time. So you can ask them, did you have this or that? And what was your diet like? Did you have any previous chronic obstructive pulmonary disease? Did you smoke, etc.? Did you have stress? You can ask various questions. And basically, you're comparing their histories. And then you can draw conclusions. That, in essence, is the case control study. But you're doing it all at one time. So let's go to the next example, which is an example from dentistry. My research question is periodontitis a risk factor for oral cancer? So my study setup is, I take 100 cases. These are patients diagnosed with oral cancer. And I take 100 controls. These are patients without oral cancer diagnosis at any point in their history. And I'm comparing the periodontal status, periodontitis, but also some other things. So I'm looking at decade missing fill status, oral hygiene, using the Silnes-Low plaque index, and periodontal status, probing the pocket depth, and looking at clinical attachment loss. And I'm just comparing that. And if my hypothesis is that those with periodontitis are more likely to develop oral cancer, I would expect to see more periodontitis in that group. So it's a simple comparison. And again, you can read the detailed paper later. What is the issue here, though? How do I know I'm not in a chicken and egg situation? So let's say I did find that people with periodontitis were more likely to have oral cancer. Did the periodontitis actually lead to oral cancer, or was it just the case that someone who has oral cancer finds it difficult to keep their mouth clean, and that then leads to periodontitis? So, what comes first? This is one of the limitations of the case control study. And this is where you have the next study. So you can see, I hope by this time, that each study builds on the following study, like it becomes stronger in terms of causal association and causal inference. So cohort studies, instead of starting with who are the cases, who are the controls, you start with who is exposed and who is not. And you make sure, so again, if you were taking that dental example where you were looking at periodontitis, does that lead to oral cancer? You would, when you recruit your patients, you would make certain that none of them have oral cancer at the start of the study. You would then divide them up. You would do your, dental checkup, and you will divide them into those who have periodontitis and those who don't have periodontitis. So your exposed and unexposed group. And then you will follow them up in time. And at regular intervals, you would check to see of interest and cancer in the groups that had periodontitis. And that is it, essentially. This is a very useful study design to also determine natural history or sequelae of disease and incidence of new cases of disease, because you're studying people over time to see who developed something. You're very sure at baseline that someone did not have the outcome of interest. So in the periodontitis case, here, 100% that is not the oral cancer which is leading to a degradation of periodontal status. It is the other way around. It was periodontitis which is actually leading to the increased risk of oral cancer. So that makes it stronger in terms of causal inference, because the exposure definitely precedes the outcome. There are two types of cohort studies, and I will talk about them diagrammatically. So the cohort study is no direction of inquiry is to the right is showing that you're going in the future. So let's say if you focus on the present is where you are as a researcher. You have recruited patients to your study. And at this point in time, when you're starting your study, you have two groups, which are exposed and unexposed. And then you follow them up in time to see who develops the outcome in the future. The issue with this is, depending on what you are studying, you might need a very long follow-up period. So for example, if you're studying cancers, the latency period of solid cancers can be anything from 5 to 10 years. Now that is a long time to be keeping a study open. You may have lots to follow up, plus you need resource, which may be up of the base. Great in principle, but it is really expensive. It can measure incidence of different diseases because, as I said, you're starting out with your population at risk that doesn't have the outcome for sure, and then you're seeing, do they develop that over time? I've talked about the other points, so I'll move on. There is another cohort study design, which is called retrospective cohort study. Now, again, I want you to focus on the arrow which says direction of inquiry. It looks very similar to the previous diagram I showed you, but here, look at where present is placed. The present is where you are as a researcher. Let's say you are lucky enough to be in a country or in a scenario where you have access to historic records, healthcare records. Like in the UK, we are really lucky because I have, I've got primary care records from GP practices starting from 1987. So I can take those records at this point and say, well, I want to look back in time. So let's say if I look at the records that started in 1990, work out who was exposed and who was unexposed, depending on what my question is. Let's say it was irritable bowel syndrome, something like that. I'd see who's exposed, who's unexposed in 1990. And then because I'm in the future, I can jump across to data from 2023, let's say, because 2024, I may not have accumulated enough. And I say, who actually then developed colon cancer? So the direction of the inquiry is still the same because I'm still moving future. So, I still know for certain exposure happened before the outcome, but because I have all these historical records, it's almost like I can travel back in time from the future to look at that. Now, hopefully that makes sense to people. The advantage of that is you have the advantages of a cohort studies. You have really good causal inference, but you don't have to wait years and years for the outcome to happen because that follow-up time has already accrued. Now, I don't know how lucky you are in India right now, in Ludhiana right now with your healthcare records that you can do this. So you may only have the option of prospective cohort studies. Now, maybe it's not such a problem for you because it depends on the outcome. So if you're looking at an outcome or a disease that can happen really quickly, you might be able to do that in a year or maybe in 6 months. So let's look at a cohort study example. So research question is oral leukoplakia associated with a higher risk of progression to oral cancer? Now, in this case, this was a study which was done in the US where they have really good electronic medical records. So they have all these historic records. So they were able to use the retrospective cohort study design. And the researchers were present, but they were able to go back in time and then follow up patients through the records. So here, patients with oral leukoplakia were the exposed group. Those without oral leukoplakia were the unexposed group. The outcome of interest was oral cancer. And you can see the study period. They had a 15-year follow-up period. If you had done this as a prospective cohort study, that's not going to happen in one MD thesis. And that's not even going to have, that's a long-term commitment. That's CDC committing to studying to something over the generations, and maybe you have intermediate measures that happen that, different cohorts of MD students take. Right. So that was the observational study designs. Let's look at randomized control trials. This is the first of the the most popular. I'm not going to do a lot on this today. It is the interventional study design. It's typically used to evaluate the efficacy of an intervention. Because you have an intervention, you would have an intervention group or an experimental group and a control group. Now, the control group, it depends on what your intervention is. So if it was a pharmaceutical intervention, a pill, you might give a placebo pill, a pill that looks, feels, tastes the same as the experimental treatment, and the patient will know. And you can even blind the study investigators or doctors giving out the pill. You can even blind the statisticians. So no one knows. So it's a really true experiment. There's no contamination. However, for many procedures or interventions, you cannot actually have a true placebo. So in that case, the control group usually receives the standard of care. So there's and the idea is that the new treatment you're testing is the experimental treatment. Now, like in the cohort studies, at baseline, you want to check that all participants are free of the outcome of interest. Now, usually in randomized controlled trials, when you're testing the efficacy of a medical intervention, usually you're looking at averting a failure or averting a disease, because it's usually that it should have a good effect. So it may be, maybe if you're looking at cancer again, like maybe it's a prevention of cancer, or maybe it is like prevention of a recurrence, like secondary metastasis from a cancer. So initially you would rule out that any participants have that, and then follow them up in time after they've been assigned to treatment or standard of care and see who has the metastasis, who doesn't. You would first recruit the patients, and then you would randomly assign them to treatment or control. So you don't do the other way around. So you don't go to patients, oh, we're having an experimental trial, who wants to be in the experimental treatment group and who doesn't? That's not going to work. It will bias your sample completely. You will then follow up both the groups to determine who develops the outcome. I've talked about blinding. Blinding is a nice feature. It means that the patients don't know which group they are in. The investigators don't know, the study doctors don't know, the study analysts don't know. It's not always feasible. I mean, in a surgical procedure, again, you definitely can't blind the surgeon who is giving the mock incision. Similarly, in some kind of like in a dental procedure, it's going to be really, you can't blind people for that. You might be able to have some degree of blinding of the patients, depends on what the intervention is. So let's look at an RCT example from dentistry. So this was the research question. What is the effectiveness of preformed pediatric zirconia crowns compared to preformed pediatric stainless steel crowns, or SSCs? So here the intervention group that received the experimental treatment was the zirconia group, and the control group is an active comparator group. What that means is it's not like you are still doing something. So there is an active treatment, but the active treatment is the standard of care. So that's the stainless steel crowns. Now in dentistry, this becomes quite fun, because you can't do this in other domains so much, is you can do a split mouth design. So you can take pairs of, so in this particular, or let me go back a few steps. So a split mouth design is where you give the treatment, the experimental treatment in one half of the mouth, and the control treatment in another half of the mouth. Now, this might be difficult to work out depending on what the treatment is, how ethical it is. You don't want to give treatment just for the sake of giving treatment. So that's important. But in this situation, they took pairs of primary molars in the same arch, with each receiving a different treatment. And the only thing they randomized was which tooth will be assigned the stainless steel crown first, which is the standard of care. And here the outcome measure was absence of a major failure. So what you wanted to know is essentially is if this treatment works, you should not see signs and symptoms of irreversible pulpitis or periradicular periodontitis, which would be considered a failure of the treatment. As I said before, you can't blind. Like, it's open label. Open label is where there's no blinding. So patients are not blinded, study dentists are not blinded. You can only blind the study statistician. Interestingly, they had a follow-up period of 5 years. So this is also quite a lot of investment, time, and resource into this example here. So this is quite useful, having the split mouth design, because sometimes there are concerns like, are the patients really comparable? Maybe the patients who receive the treatment and receive the controls are not really completely, there's some systematic differences. Now, in principle, a randomized control trial should not have those issues if you truly select a random sample and if you have true random assignment of treatment and intervention. But in dentistry, this can become stronger because they're all this, like, that the conditions in the mouth and behaviors can affect the success of a treatment. So by having the split mouth design, you have even more robust estimations of the effectiveness of that particular intervention. So you can read more about this for the study protocol. The study is not yet finished. Just for completeness sake, I want to discuss cluster randomized controlled trials. Individuals to having an intervention, health clinics, hospitals, schools, or districts. Now, the outcomes can be measured either at a cluster level or at an individual level. Now, this is very useful if you're looking at, like the example we did of the ecological study of the school fluoride mouth rinse program in Japan. Now, that was a natural experiment. The researchers didn't intervene, but you could actually have an RCT like that, where you could say, okay, we don't have a program like that in place. Maybe let's look at Ludhiana, take different areas, and just introduce this school-based fluoride program, look at the outcomes. Now, the outcomes can actually be measured at an individual level. So you can send your teams of people, they can do a survey, carry out DMFT sort of measures, look at mean DMFTs at the individual level, and then you have a more robust response. So this is what makes cluster randomized control trials similar to ecological studies, but different, because here you're actually intervening, and here you can actually take measures at an individual level. Now, cluster randomized control trials should only be used when you are looking at these group level interventions where you might contaminate individuals. So for example, like let's say you are delivering a health education intervention in a school or a locality, you can't realistically or ethically tell people over there, yes, now we've told you this, and so then you can have excellent oral hygiene, but please don't tell your friend who just happens to live across the road and happens to be in a different district or a different boundary. That's just not ethical. Or don't talk to your friend in the other school about, I've told you about this great brushing technique. So for that, it's what you have. So in those scenarios where contamination may be an issue, you actually deliver these interventions at the cluster level, but also make sure that the control clusters and intervention clusters are not coterminous, like their boundaries are not touching, so that reduces the chance of contamination. Otherwise, I would say individual RCTs are much more efficient than cluster trials. You need fewer participants to detect statistically significant differences. So only go for cluster randomized control trials when it makes sense, when there is a cluster level intervention. So an example from dentistry, what is the effect of a nutrition and hygiene education intervention on oral health behavior? So the intervention is this nutrition, hygiene, education intervention. Control is standard practice. In this situation, it would be, people giving opportunistic advice, but there's no structured education program in place. The clusters were villages, which were randomized to intervention or control, and they made sure that the intervention villages were not touching or not sharing common geographical boundaries with control villages. That was to reduce contamination. The outcome assessed was oral health behavior, and the outcome was assessed at individual level. Now, I've talked about this before. Cluster randomized control trials are interventional studies because you as a researcher are intervening. It is not an ecological study, which is observational. Cluster randomized control trials, you can take individual measurements of outcomes, whereas an ecological study you cannot. Therefore, in a cluster randomized control trial, you will not have the problem of ecological fallacy. Right, that has been quite a whirlwind. So I'm just going to quickly summarize. Epidemiological or observational study designs include ecological studies, cross-sectional studies, case control studies, and cohort studies. Ecological studies, these are the population level studies that compare groups. They use readily available aggregate data. They are good for studying the impact of national policies. Cross-sectional studies or surveys involve measurements in a slice of the target population at a single point in time. They're great for assessing prevalence of disease and capturing data on risk factors in a population. Case-controlled studies start with a group of individuals who have the outcome of interest, that is cases, and another group of individuals without the outcome, that is controls. And then they compare their past exposures to determine if there's an association between a given risk factor and an outcome. Very important, they cannot be used to assess incidence or prevalence. For that, either use a cross-sectional study or a cohort study. Cohort studies, on the other hand, start with a group of exposed and unexposed individuals and follow them up in time to see who develops an outcome of interest. And a way to remember this is a cohort. Cohort comes from that, from Roman times, there would be cohorts of Roman soldiers marching together. So just imagine that you are marching together along with your participants in time. So you're following them up to see who develops an outcome. Interventional or experimental study designs include randomized controlled trials, and they involve the researcher intervening and assigning study participants to an intervention or control group. The control group can be given either placebo or standard of care. And finally, a special type of a randomized controlled trial is a cluster randomized controlled trials, where clusters rather than individuals are randomly assigned to an intervention or control. So that's all from me. I'm going to see if I can stop sharing. Right. So, any questions? And I don't know, Joe, if you're mediating this.
Thank you, ma'am, for that well-rounded yet comprehensive presentation that give us an overview of all the study designs. Now, may I request anybody who is participating online, if they have any question, they can unmute and they can ask their questions now.
My goodness, I seem to have stunned everyone into absolute silence. Well, does anyone want to know why you cannot use case control study designs for measuring incidence?
Hi, Dr. Puja.
Oh, a question. Excellent.
Yeah, can you please elaborate something about retrospective cohort studies?
When you say elaborate, do you want me to go over the study design again, or is there a specific question about that?
No, it's like prospective study design is like very much familiar to us. But what about the retrospective study design? How is it supposed to be designed? What are we looking into when we are doing these type of studies? And are we going from, I mean, we are going backward. So is it from the outcome to the design, or what type of study design is it?
You are still looking forwards, but this will only work if you have historical records. So let's say there was a particular hospital, and I don't know what the position is in CMC and CDC or in other hospitals where you are working right now. But let's say you have been very diligent in collecting dental medical records for many years, and these are dated records. So you can go back to those records, and let's say you started collecting them from 1990. You can say, I want to see if oral leukoplakia is leading to a risk of oral cancer, even in my populations. And let's say there was an oral pathology or oral diagnosis department, and they have they've got all those records. So you can say, let me go back to my records from 1990 and see if there were any people who had oral leukoplakia. So you find some and you say, excellent, so I have an exposed group. What you can then do is you can just randomly select another group of people who came to the department but were not assessed with oral leukoplakia. So you definitely know they didn't have that, but they could be your unexposed group. So you already have this data. So and then you say, okay, now let me flip through their records and see if any time between that initial diagnosis or that initial visit for the unexposed and this point, which is 2024, they came back with a diagnosis of oral cancer. If they did, you just record that. Now, it really depends. So that's why it's called retrospective, because the direction of inquiry is still the same. You're going forward in time. You're starting with exposed and unexposed, and you're ending with outcome in the future. But you, as a researcher, are actually looking back through these retrospective records and then coming back in the future. Does that make more sense?
Yeah, a little bit. Thank you. I think I need to read a little bit more on that, because this is very confusing to me. Because we are starting from the outcome and then we are going to that exposure and not exposed part.
No, you're not starting from the outcome. You're still starting from the exposure. But
So,
instead of
for
having to
example,
ascertain the exposure in 2024 at this point, you say, I wonder if in 1990, because let's say you know that you want a 5 or 10-year period follow-up, say, I'm here, but instead of starting to recruit new patients in 2024 and then following them up for another 10 years, let me see if I have any data from the past on people who had oral leukoplakia that I can use. So you go back in time to your records and say, oh, wonderful, I have this wonderful set of records from 1990. And I know that there were some people with oral leukoplakia and some people who didn't have that. And let's assume they always came to your hospital and there's no missing data, there's no loss to follow up. These are big assumptions. And you say, now let me see, because I'm in 2024 at this point, I have that whole record in front of me. Let's see, between 1990, when they were first diagnosed with oral leukoplakia, so that was your exposure. So you're starting with that. Did they ever develop oral cancer? So you are still starting with the exposure and then seeing who developed oral cancer. And you're doing that similarly with a group of patients who may have attended clinic in 1990 but didn't have oral leukoplakia, and say, let's see if any of them developed oral cancer. But your entire study, your outcomes will have been ascertained before the end of 2024, because you're looking back in time rather than after 2024, 10 years down the line.
yeah, thank you. I think that's my question.
Okay.
Anybody else from the online participants wants to ask any questions? Please unmute or post your questions in the chat box. Sorry.
Hello, Ms. Puja. Yeah, so
Yes.
I actually have a very small question, which is a bit practically oriented, actually. I was working a set of data sets recently, and we came across a time where we had two options of like collecting the mean. That is, we have the mean as well as the weighted mean approach. And I was just looking at like how is there? Do you know? I know that this is slightly off topic, maybe, but is there any specific reason for choosing a weighted mean, like depending on like a sample size or some approach like that? Is there any particular scenario where you choose between a mean or a weighted mean? What makes you choose between that? And if there's a sample size estimation that kind of makes any change to those choices?
So this usually is in the context of survey. So I don't know, is that what you're planning to undertake a survey? And
yeah, meaning if you're doing an experiment and you have a I work more towards the laboratory side. So PP is something related to an interventional clinical trial, or like where you are doing an interventional medical approach, and you know that regarding that.
Generally, no. So you don't decide a weighted mean or an unweighted mean depending on the sample. It's really like without too much context, it's essentially for everyone else, so that is relevant to everyone else. If there are certain factors that you're studying that you want to weight more. So all that means is you're like, this is such an important factor that I can't, like if I'm giving a score of 1 to everyone, I can't just give that equivalent score. I have to give this twice as much weight because it's so important. That in a very simple sense is the concept of weighting. You can also have sometimes, if you're in survey methodology, when you're taking different sort of like substrata of your population, and there might be certain groups you want to give extra weight because otherwise they'd be underrepresented. So those are the areas, or those are the scenarios in which you might weight things differently. In a laboratory scenario, again, without understanding the full context, it might be that whoever, your whole study team has decided, or maybe it's in the literature, that a particular factor that you're looking at is so important that it needs weighting to make it relevant. And that might be the standard in your care. But normally you won't do it just for the sample size. So that's more a measure of effect and how you're measuring things, if that makes sense. Without the context, I'm afraid I can't provide any more
Do you
detail.
have a few minutes where I can give maybe a small context for it?
Anyway, Joe is the boss.
Yes, Arun, you can get in touch with ma'am.
Thank you for that.
We have a question from one side.
Good evening, ma'am. I am a PG first year resident. So actually I have two questions. The first question is, ma'am, regarding the thesis design that I am planning. Actually, planning a study in a split mouth study in which I am planning to give conventional dental implant versus surface modification with calcium dental implant. So I was planning to have a split mouth study. As you said that the split mouth study will eliminate the question that patient factors that will decide the success and the failure of the dental implant. So in that case, will it come under a RCT? Like control group will be the conventional implant side and the interventional side will be the CA implant. So I have a confusion there. What is, does it fall under the RCT? What will be the interventional group?
It's definitely a randomized controlled trial because you are intervening. You are doing some procedure in the mouth, and you are going to be randomly assigning one side of the mouth to a particular treatment and another side of the mouth to another treatment. So in here, whatever is your standard of care, so what is the standard approach you will take, will be the control. And the new treatment, the experimental treatment, which you're not so sure about, which you're really interested in evaluating, will be the intervention arm.
Okay. Thank you, ma'am. My second question is, while reading the articles, especially the retrospective studies. So whenever there is a limitation column in these studies, the limitation is written that it is a retrospective study, and the limitation is that it is not being followed prospectively. So the limitation is that the study should be carried in a prospective manner. So why is it so that the retrospective is itself a limitation of a retrospective study?
I mean, it comes down to the example that I was giving, that you're going back in time to see your retrospective is you are reliant on having excellent quality records with no missing data, because you cannot actually really go back in time to say, oh, I don't know, did these people actually not have oral cancer, or did they just not turn up, or did someone just not record it there? So that is a limitation. Whereas prospectively, when you're starting from scratch and you're following them up in time, and you have a particular measure that is really crucial to your study, you will go out of your way to actually make sure you ascertain it. And where there is loss to follow up, like, you don't know the outcome because that patient has suddenly maybe moved houses and you can't follow them up, you know for certain what has happened, and then you can deal with it in the statistics accordingly. So the retrospective limitation is really about if there is this uncertainty about how good the data is.
So the reliability of the data is questioned in retrospective studies, is what you are. Okay.
Yes. And it can be questioned even in prospective studies. It depends how good your data is. Like, for example, in the UK, as I said, the data are very, very good. Even then they have limitations, but we understand the limitations. So if you understand very clearly what the limitations are, you can adjust for them in the statistics and the study design.
So ma'am, if we are designing a study to determine the clinico-radiological correlation of a disease that has a rare occurrence in nature, so for that, we plan to take the medical records of the patients who have already been diagnosed with that disease, and we go 2 to 3 years back in time to see whatever patients we have. We establish the clinico-radiological correlation if they are having, and we also go 1 year forward in time, like prospectively we go, and we see whatever OPD comes in and all the new patients we see that are coming to us and are having that disease. So if we are combining both these approaches, so it sounds like an ambidirectional study for both the combining both the retrospective and prospective cohort. So what does that study design will be named, and what will it look like if we can actually do it?
So first thing to clarify is it the same group of patients that you're going to look back into their history and you will follow up, or is it a different group of patients?
Different group, ma'am. Matlab, for the retrospective ones, there are completely different set of patients who have been already diagnosed with that disease, and they are coming up. And in prospective, we are expecting new set of patients that will come first time in the OPD.
So it is not an ambidirectional study in that sense. You will report it as part of this research, we conducted 2 studies. One was a retrospective study based on case records and histories of patients who had already attended the OPD between this period and this period. The second study is a prospective study, which will be studying new patients who attend the OPD from this period to this period. And then you say, when we draw the conclusions, overall conclusions, we're going to take into account evidence from both the studies. Now, you have to ask yourself, what is the value of, if you're doing a prospective study, apart from the fact that maybe you'll have advantages in not having to do that much follow-up, depends on what you're looking at, how much follow-up is needed. Is it actually adding value, or is the retrospective enough? Or actually, if the prospective is good enough and you've got your follow-up time and that is sufficient, why are you increasing your work by doing a retrospective as well?
Because the viewpoint is like, as the disease is rare in occurrence, so to gather enough sample size
Okay. All right. In that case, it makes sense. So that's a clear justification. But you will say that you have conducted two studies, and that's pretty often. Like again, for an MDS MD thesis, you don't need to do that much for a PhD. But a PhD thesis is normally, and I give the rule of thumb, think in terms of 4 to 6 papers. So there's an overarching objective, and there might be 4 to 6 studies that happen in that. So you might do, as part of that overall PhD, a case control study, a cohort study, other sort of study designs which we haven't covered today. So that's perfectly fine. It doesn't take away from you. And in fact, what you could do is you could publish one paper on the retrospective, one paper on the prospective, or you can, as you're doing that, so you have these mini wins. You'll have to see, how much, like if it's too rare, and if you get nothing, you might not have statistical significance, but it might still be worth publishing as like a little case series or report there. And then you have your final study, which is like, the overarching conclusions. Is this associated with this? When we take into account both these studies, this might happen. Or do the retrospective study separately, publish it first, and when you've done the prospective, also refer back to those results. So these are the various options, but there is no such terminology as ambidirectional study as such. So you report it as like, either two studies which were done together to answer in a more robust fashion the question and presented in one thesis or one paper.
Thank you so much, ma'am.
Any Thank you for your time, ma'am, and we'll hope to do tomorrow's one with a more practical thing in mind. They will come with their protocols, and maybe they can do the sample size estimations side by side. How do you suggest?
I think if we get into detailed protocols tomorrow, it might be there's not enough time. So what I suggest is I will show you some things, some basic study design, basics calculations, and then you go back and attempt those yourself. And then if there are any issues or something, just let me know. If you can collate all the issues and send them to me, then we can see if we can do something in the future. There's just some troubleshooting.